experience and depression. Yeah, I have a very depression experience on lateral epicondylitis. Let's start. So lateral epicondylitis remains the most difficult case, I think, in my practice. I'm sorry, I a bit disagree with you, Dr. Prasit, because mostly you say it heals conservatively. I agree, but I work in Jakarta, so it's a third referral hospital. So they usually come in a very weird presentations. Yeah. So when a patient come to my practice with a lateral elbow pain, for 5 minutes I have to finish one patient. I definitely diagnose as a lateral epicondylitis. This is a straightforward case. But for a lateral elbow pain, everybody has to be reminded that we are facing two problems. We can have an intra-articular problem, radiocapitular arthritis, OCD, and plica. Extra-articular, of course, the culprit ECRB, the instability, and maybe once in a lifetime, you are very unfortunate, you will have to face the radial tunnel syndrome. The treatment of tennis elbow, I agree with you. Everybody will heal with a conservative treatment. I wish everybody come with this and heal with conservative treatment. And nowadays, arthroscopic intervention is actually, I agree with Dr. Artit, it's a show, arthroscopic, yeah. I do open surgery. Open surgery is working as well as arthroscopic. So I'm not ashamed to say that sometimes my ego beat the patient need. I do arthroscopy, yeah. So why do you do arthroscopy? Because I can preserve LCL, I can address intra-articular pathology, I preserve the common extensor tendon, and by this premise, I convince the patient you can go get back to work faster than the open surgery if I want to do arthroscopy. So arthroscopic debridement from the hallmark paper by Dr. Cohen, everybody knows this. If you make the right portal, you avoid neurovascular injury as seen as the previous presentation. You can target the capsule and ECRB very well and shoot the target. But the pitfall, everybody know, not going to pass the equator of the radial head as to avoid the injury of the LUCL. So these are the common arthroscopic ECRB release in the practice. You scope in from the proximal anteromedial portal, you visualize the radiocapitular joint, you save a bit, and you see the capsule release, which is, sometimes you can see the capsular tear, and you can see the whitish tissue here. This is courtesy from my friend. The white tissue is the ECRB. You attack this tissue, you are not sure, you change the scope to 70 degrees to see the whole insertion. And then voila, you can see the reddish tissue, which is the ECRL. By performing so, actually you have finished the surgery. Mostly it will take you around 20 to 30 minutes. If you just started your session as an elbow surgeon, maybe you can take around 1 hour. Believe me, usually it will be, you spend more time to set the lateral decubitus, the tourniquet, the everything, and the procedure just need 20 minutes. Okay, so result is a full stop. Arthroscopic is good, open is good. But we love arthroscopic because it's for the show. Some patients are not improving. Why? Okay, there are two reasons, in my opinion. I am impatient, or the patient is impatient, or maybe something else. So am I missing something here? Maybe lateral epicondylitis does not always equal to ECRB pathology, maybe, which is very unfortunate. Mostly we will not have this mistake. There are many forms of lateral epicondylitis. We can have a capsular tear. The right picture is the radiocapitular joint widening, or you can have a snapping annular ligament, which is shown by the previous presentations. Let's get back to the previous time. In 1955, a landmark paper by David Bosworth, he described that he has already treated the lateral epicondylitis patient with conservative and operative treatment. Despite doing operative treatment to those patients, he reported in his paper, some are not improving. So he introduced the Bosworth technique. Of course, every orthopedic surgeon would like their name on the procedure or the field. He introduced three kind of operations. The first one is to release the extensor only release. Of course, there's no scope at that period. Watanabe find the scope in 71. And then the second one, he take out or release the synovial fringe. And the last one, he took out the orbicular ligament. We don't know, I didn't know what is the orbicular ligament release. It's the annular ligament actually. So let's first things first. What is the synovial fold? Why this is important? So Suzuki Ko in Japan Elbow Society, she described, it's a she, 28% of the radial head actually have a synovial fold in 49 specimens. So this is like our plica in the knee. So you have repetitive motion, perhaps you can have a high inflamed plica. So as the elbow, so if you have repetitive extension and pronation, you might have a hypertrophic fold in your plica and become pathologic. So I become confused there because there are so many terminology. You can read synovial fold, fringe, elbow synovial fold syndrome, plica syndrome, and plica. Because I'm confused, it actually forced me to do a study. So I include all the study in, 2021, 27 studies included. And these are patients with lateral elbow pain, in which 53% of it are diagnosed with lateral epicondylitis. If you check those studies, we can find that most of the patients who have a pathologic plica, not all the plica is pathologic. They are mostly innocents. If it's located in the posterior lateral side with a more than 3 millimeter thickness, and it covers more than 3 millimeter of the 1/3 of radial head, mostly it's pathologic. So I share this information with my radiologist, and I include this knowledge into my decision making in the clinic. So why the synovial fold is causing a pain? So in 2018, I dissected a cadaver of the elbow. So I described the nerve ending. We know in our medical school, Ruffini, Pacinian, and Golgi corpuscle and the free nerve ending. Here is the proprioception. This is a nociception. So it turns out that the synovial fold at the posterior lateral capsule, which is very near the plica, it's very rich of nerve ending. So I thought maybe this is the cause of the pain. This is the source of the pain. So again, I checked the literature. If we remove this plica, will we have a benefit of the surgery? So in 2020, I conclude that from a bunch of paper, systematically review, removal of the pathologic plica may relieve the lateral elbow pain. So let's move to the second structure, which is the orbicular ligament or annular ligament. So basically, we have a lot of study from the hand section that annular ligament contribute to elbow stability, full stop. But if you reset the upper portion of the anterolateral ligament, it will not cause instability. So in a case like this, when you see a snapping lateral elbow, this is the anterior part. If you have the snapping, you can actually resect 1/3 of the plica, which block the radial head and make an impingement. Perhaps this is the cause of the pain. This is my illustration to ease the explanation. If you have repetitive extension and pronation, the fold become hypertrophic because in pronation, the fold goes inside the joint. When you supinate, the fold went outside the joint. So these are the example of performing a arthroscopic annular ligament resection. It's not difficult. It's easy, especially if you have a hook ablator. So lateral epicondylitis actually is not just lateral epicondylitis. It may appear or coexist with the radiocapitellar capsule lesions, synovial plica, or an annular ligament. We describe the arthroscopic management for the lateral epicondylitis with a snapping radiocapitellar joint in this Isako's book chapter. Okay, the result, how was it? So, of course, this clinical outcome study that I performed is have many limitations. I must confess, because there are not many patients have this problem. Thank God. Only 22 patients, but this is the biggest limitation in a very small retrospective study. Might have a type 2 error, but the follow-up is 30 months. The DASH score is 3.6, MEPS is 84.3. Move to another one. Nowadays, we have been faced with many patients who would like a steroid injection. Indonesian people, our people, we like steroid injection. I'm not sure about Thai people, but they think that the steroid injection is the gift from God. It will cure every of my joint pain, right? So this is a lady, mid 50. She got a lateral elbow pain. The clinical impression is lateral epicondylitis with a varus laxity test is positive. So by looking back at this X-ray, the left side is actually the affected side. We have a radiocapitellar joint widening, and compared to the normal contralateral, which is not widened. At the MRI, I can see a complete humeral detachment of the LUCL and RCL. So the direct diagnosis is a PLRI, and it was confirmed with the EUA. What did we do? We did a joint arthroscopy diagnostic scope. We'll reveal a radiocapitellar joint widening. And this is a arthroscopic LUCL reconstruction with the palmaris longus. And it looks like a lateral tenodesis at the knee, or ALL, So this is, the left side is before the radiocapitellar joint tensioning, the graft tensioning. The right side is after the graft tensioning. Let me repeat. Actually, arthroscopic LUCL reconstruction, again, I think it's just for a show. We can also do an open one, which is very easy and straightforward. Okay, elbow is a weight-bearing joint. I think I a bit disagree with you. Elbow is a weight-bearing joint because we are using the elbow like this. Okay, we never use the elbow like this because we are always give something like this. So if we extend our elbow, actually the weight of I'm small. Maybe if you are bigger, you can have the weight of the elbow weight much more bigger than mine. So if you extend the elbow and you turn your head like this, actually these are the lateral side of the elbow is loaded with a lot of strain. So when you have this motion every day, like the lady who work in the market, actually the LCL will fail as a static stabilizer at some time. So in this room, who never have a lateral elbow pain? You have? After your heavy surgery? I have, But I know it will heal, so I refuse to have surgery, So the ECRB is overloaded and inflamed and painful. This is the cause why we have instability pain in lateral epicondylitis. So again, this is a paper in AJSM 2021. We review a bunch of lateral epicondylitis with elbow instability. In fact, this is not a myth. This is a fact. The PLRI can coexist with the tennis elbow, either as a sequelae to the steroid injection. I'm sorry, I blame the steroid, and maybe as a concomitant findings as well. So, very unfortunate. So, okay, I almost done. So most injection, if perhaps you can say that, you can argue that the injection is innocent. Maybe the steroid doesn't go to the ECRB. I agree. The Danish Agenda group, they show that most injection is a hit and miss. Only 30% is actually the culprit. Actually, is inserted in the ECRB. 60% is out of ECRB, is intra-articular. So perhaps if you look at this, you have the MRI like this, the widened radiocapitellar joint with the detachment of the lateral side of the ligament. You can have the scope picture like this. So you might want to be careful to do something with the lateral, you might want to stabilize the lateral part of the elbow. Last but not least, I would like to take a moment for us to remember why we have a failed tennis elbow surgery. So in 2022, we have a chance to write a chapter for Mihata textbook. So I think we have to think again why we have failed because of 3 reasons. Maybe I have a wrong patient and wrong diagnosis. Maybe I did a wrong surgery. Maybe it's a wrong timing. These are the protocol. Wrong timing, it means I'm not patient enough. There are not enough rehab. Wrong patient, maybe it's some personality issue or compensation. Wrong diagnosis, incomplete surgery, or iatrogenic surgery. These are the sad story of iatrogenic injury. So we can see a lateral elbow pain patient who underwent several surgery and there is a palpable cystic mass. I borrowed this picture from my professor. So I hope I never met this kind of patient. So when he debrided, he found a large huge gap in the lateral side of the elbow. At that time, he performed an unconeus muscle transposition, which we describe in this ISSA-KSES chapter. So we don't do a lot because we hope that this kind of patient will not come to us. Yeah. But if they do, actually, you can do this. Yeah. So treatment of the tennis elbow, still, I hope the conservative treatment will fix all my patient problems, so I do not need to do surgery on him and will not cause any complication. Last but not least, there is a paper recently by the Bone and Joint Journal 2023. Actually, is it time to reconsider the indications for surgery in patient of tennis elbow? I think this is very supportive to your talk in Seoul. Yeah. We cannot predict who will fail. This is the problem. This is my ego. That's why I have this presentation is for my ego. And we cannot know when the treatment has failed. So normally people will write 6 months after failed conservative treatment. Actually, maybe he's not failing yet. Yeah. So we need to wait. So my conclusion is I'm still depressed. The lateral epicondylitis still is the most difficult case in my practice. Thank you. And please come to our IOSMA meeting in September, the 3rd week in Surabaya. Thank you.